Dear colleagues, today I am presenting a case of thanatophoric dysplasia. The term thanatophoric comes from the Greek thanatos and phoros, which means bringing death. It is a form of dwarfism characterized by micromelia, that is, a severe shortening of the long bones and therefore of the fetal limbs. This most frequently affects the rhizomelic segment, meaning the part closest to the fetal trunk, such as the femur and humerus. But it can sometimes also involve the mesomelic segment, including the tibia and fibula or the radius and ulna. Two forms can be distinguished, both of which are characterized by the presence of a narrow hypoplastic thorax with a typical bell-shaped or bud-like appearance, and what is called the step sign, that is, seen on sagittal scan. Along the fetal profile, at the point where the thorax transitions to the abdomen, it is possible to see a step-like appearance. This is due to the hypoplasia of the thorax, while the abdomen appears more rounded or globular. Type 1, which is the most common, is characterized by predominantly rhizomelic micromelia, a curved femur with a telephone receiver appearance and flared metaphyses, and a skull that usually has a regular morphology. Type 2, which is rarer, is characterized by predominantly rhizomelic micromelia, a femur that in this case is straight, and a cranial anomaly due to craniosynostosis, that is, a premature closure of some sutures, in this specific case the coronal and lambdoid sutures, which consequently leads to an increased growth in the frontal region, with the typical frontal bossing visible in the sagittal scan and also growth laterally in the temporal region, giving this typical appearance of the skull that looks trilobed like a clover leaf, so a classic macrocrania, which is often associated in the first trimester and more frequently in the second. Hydrocephalus and an excess of soft tissue involving the limbs. The dysplasia is associated with a mutation in the FGFR3 gene, which encodes a protein that is overexpressed, namely the fibroblast growth factor receptor 3. The transmission is autosomal dominant, therefore, since it is an anomaly in a lethal form, the mutation is usually de novo, with a very low risk of recurrence. FGFR3 is also mutated in other anomalies, among them chondroplasia. Differential diagnosis can be attempted via ultrasound as they actually have different characteristics. In chondroplasia, in fact, we do see rhizomelic micromelia with short femurs, but they are not curved. There is macrocephaly with frontal bossing, brachydactyly with short fingers, and a trident-shaped hand. The diagnosis of thanatophoric dysplasia can be suspected as early as the first or second trimester. Due to the reduced biometry of the long bones, which are measured below the 3rd percentile, especially in the proximal segment, that is, the medial region such as the femur and humerus, which is characteristic of rhizomelic micromelia, often in the first trimester there may be increased neutral translucency, and then the classic bell-shaped thorax, so a bell-like appearance, a curved femur in type 1, and a cloverleaf skull with craniosynostosis in type 2. In particular, craniosynostosis requires differential diagnosis with other syndromes in which a cloverleaf skull, brachycephaly, frontal bossing, or macrocrania may also be present, as in the case of Pfeiffer, Apert, or Cruzon syndromes. However, in these conditions, there is never an association with micromelia, and therefore short or curved femurs, as seen in thanatophoric dysplasia. Another differential diagnosis is short rib syndrome. And then there is datilia, which shares some features such as being a specialty at the control centers. Narrow chest, short ribs, and micromelia. But unlike thanatophoric dysplasia, polydactyly is present, which usually does not occur in the conditions we will discuss shortly. In particular, in the case of an exam, patience is required, as our observation is added to perform a first trimester screening test. We check the neutral translucency, which appears thin at 1.4 millimeters, and the nasal bone is present. But what immediately catches our eye and attention is that in the truncal spaces there are not 3, but rather 2. It is very likely that there is an abnormality of the posterior cranial fossa, with a communication between the 4th ventricle and the cisterna magna. In the sagittal scan, we can clearly observe macrocephaly and a prominent frontal bone with the characteristic frontal bossing. In the transverse scan, we also observe a median falx that appears fully intact and complete on both sides, along with the choroid plexuses contained within the lateral cerebral ventricles, which appear slightly dilated, indicating a state of mild hydrocephalus. It is of the triventricular type. In fact, along the midline, along the axis of the cerebral face, we see the density of 2 anechoic dilatations, presumably the 3rd and 4th ventricles, which appear to be communicating with each other through the aqueduct of Sylvius, which is dilated and therefore visible. Then, when acquiring the cranial biometry, we see that both the biparietal diameter and the head circumference correspond to about 1 week more than the gestational age by amenorrhea, thus confirming the condition of macrocrania. On the sagittal scan, the CRL corresponds to the gestational age by amenorrhea and measures about 76.4 millimeters. Along the fetal profile, we observe the presence of the step sign between the chest and the abdomen, the presence of a globular abdomen with the typical appearance, and thus a bell-shaped, bottle-like thorax. In the transverse scan, we observe the stomach and ribs, which appear short. The stomach is properly filled, the abdominal wall appears intact, and the umbilical cord is normal with 2 umbilical arteries. Moving on to the evaluation of the fetal limbs, we focus in particular on the lower limb. The femur appears straight, not curved, but with reduced biometry. In fact, it appears shortened, about 7 millimeters, corresponding to 11.5 weeks compared to 13 weeks of amenorrhea. At the level of the mesomeric segment, we see a tibia and a fibula that are slightly curved and have reduced biometry. In particular, the tibia measures 6 millimeters with a value of 11 plus 4 and indeed appears shortened. Observing the upper limb, we then focus on the fetal fingers. In particular, we rule out the presence of polydactyly in both one hand and the contralateral one, thus also excluding the differential diagnosis with the condition of ribs, short ribs and polydactyly, which we can therefore exclude. The bones of the proximal segment of the upper limb also appear shortened, measuring about 8 millimeters, which corresponds to 11 weeks plus 4 days. The ulna and the radius also appear short. In particular, the ulna is about 7 millimeters, corresponding to 12 weeks plus 4 days, and the radius is about 6 millimeters, which instead corresponds to 13 weeks plus 2 days. There is also an observed redundancy of the soft tissues in the thigh and lower limb. The examination is then completed with a cardiographic assessment. We observe a 4-chamber view that appears regular, with normal valvular excursion bilaterally using color Doppler. We note normal filling biventricular. The scan between the tracheal phases is also regular, with the V sign to the left of the trachea. Thanatophoric dysplasia is a lethal anomaly. Death can occur in utero or shortly after birth due to respiratory failure caused by thoracic hypoplasia and consequent pulmonary hypoplasia. A detailed ultrasound study of fetal anatomy is essential, along with an echocardiogram, and the patient is advised to undergo genetic counseling with possible invasive testing. For the study of the fetal karyotype, amniocentesis is performed, and the search for specific mutations associated with skeletal dysplasias. In the event that the patient opts for voluntary termination of pregnancy, it is essential for the definitive diagnostic assessment. A genetic analysis is performed on a sample of fetal skin from the fetus at birth. In this case, the patient opted for voluntary termination of pregnancy. A postnatal genetic test was performed on the fetal skin, which revealed a mutation in the FGFR3 gene with a variant that is indicated and highlighted in the slide and is a typical feature of thanatophoric dysplasia type 2, as opposed to the completely different variant shown below, which is characteristic of type 1. The postnatal fetal X-ray showed a hyperplastic, narrow, bell-shaped chest with short ribs and a distended abdomen below, as well as micromelia of both upper and lower limbs. And this macrocephalic appearance, which was confirmed by the Silis scan, specifically type 2, had already been suspected during the prenatal period. Thank you for your attention.